Now let us look at a case study. A 14-year-old girl with no past illness presented with recurrent syncopal attacks over a period of 2 months. Otherwise, she had no chest pain, orthopnea, leg swelling or fever. There was no family history of recurrent syncope or sudden cardiac death. Her vital signs and general examination was normal. CVS examination showed parasternal heave. Auscultation revealed splitting of second heart sound. Blood investigation revealed normal full blood count, renal profile, liver function test, electrolytes. ECG showed sinus rhythm, right axis deviation. What is the next investigation to be done and why? So basically the next investigation we would opt for would be echocardiography. Now why? Now the significant findings are on examination, it is your parasternal heave and splitting of second heart sound. Parasternal heave, it is seen in right ventricular hypertrophy. So right ventricular hypertrophy basically can happen either because of a long-standing lung disease or it can happen because of your congenital heart disease. Now in this person, there are no symptoms suggestive of a long-standing lung disorder. So this is excluded. So now we have to look for a congenital heart disease which causes right ventricular hypertrophy. So therefore we have to look for a congenital heart disease which is looking for right ventricular hypertrophy. So when there is right ventricular hypertrophy, we should also know what has happened to the right atrium, what has happened to the pulmonary artery pressure, what has happened to the valves. So all this we will know only with echocardiography. If suppose in this person we do echocardiography and that shows right ventricular hypertrophy, right atrium hypertrophy and also you're increased in the pulmonary artery pressure, then this will most probably point out to looking for your atrial septal defects. Then you have to look for the septal defects. You can find what the defect is and based on that you can further go on with the management. So that completes this case discussion. Now the second case discussion, a 75-year-old female presented with dyspnea, lower extremity swelling, palpitations. She had a 3-year history of atrial fibrillation and 1-year history of cardiac failure. Physical examination revealed an irregular pulse, blood pressure was normal, lower extremity swelling was present, jugular veins were dilated, patient complained of pain in upper right abdominal region enhanced by palpation. ECG showed atrial fibrillation, right bundle branch block, infralateral ischemia. Transabdominal ultrasound showed an enlarged liver. So now, explain the cause and pathophysiology behind. So first of all, the age is going to be advanced, 75-year-old female. She has got problems with dyspnea, lower extremity swelling and palpitation. So all this point towards some cardiac abnormality. So this is something to do with your heart failure. So this much we get to know with this. They have given that she had history of atrial fibrillation. Directly they have given cardiac failure, fine. So heart failure is now confirmed with the history. Now they have given that she has atrial fibrillation. Now next they have given that jugular veins were dilated and that the abdominal region there is pain, there is tenderness and it is enlarged. So now this suggests that the heart failure she is having is a type of right heart failure. So this gives us an idea that she is having right heart failure. Now fine. Now how should we go about? Now here you see that a woman is having atrial fibrillation. She is developing the heart failure. So what causes atrial fibrillation? So age, the advanced age by itself can cause atrial fibrillation. Comorbidities like hypertension can cause atrial fibrillation, which this woman is not having. And congenital heart diseases can cause atrial fibrillation. So therefore in this woman we have to look for congenital heart diseases. So therefore in your echocardiography you check for the status of your right ventricle, right atrium, the pulmonary artery pressure and then you will get to know whether there is going to be a septal defect. So that also you will get to know. So whether there is atrial septal defect. If suppose the person has got atrial septal defect, I have told you because of increase in pressure in the right atrium, the current flow alters and there can be atrial fibrillation development. So therefore, ASD can be applied to this person with further investigation. We can confirm the diagnosis. The next MCQ for discussion, all of the following are potential complications of an atrial septal defect in adults except air embolism from a central venous catheter, yes. Arterial oxygen desaturation with exertion, yes. Embolic cerebrovascular accident, yes. Pulmonary arterial hypertension, definitely yes. Unstable angina. So, unstable angina, there is no definitive statements telling that people with atrial septal defect are prone to develop unstable angina. So, therefore, your answer is option E, unstable angina. So, that completes discussion on atrial septal defect.